How's it guys, and welcome back. My name is James and this is the Med Guy. Today we will be discussing a topic that really needs to be broached, and that is tension pneumothorax. We will be breaking down exactly what you need to know and all of the misunderstandings and it's not like false teachings, but like wrong or error teachings. This will hopefully clarify things for you. So let's jump into the why. When we all have been to college, whether you're in college or you've done with college, we are taught what a tension pneumothorax is. We're taught how to diagnose it, and we are taught how to treat it. The first one we tend to get quite right. We tend to explain what it is quite well. However, we don't diagnose it very well and we don't treat it very well. And that's exactly why we're making this video. So discuss quickly the pathophysiology behind a tension pneumothorax is that there is a lung and there is a cavity around the lung, or there's a space. This is called your pleural space. There is a negative pressure in the space which helps the lungs stay expanded, so that when we inhale or exhale, there is still a negative pressure in the space between the rib and the actual lung. So that then the problem is that when we exhale, air moves from the atmosphere into the pleural cavity, and then when we inhale, it doesn't go back out. The problem with that is that then the pressure in the pleural space becomes positive, which means that it's going to start pushing the lung smaller and smaller. So that's pretty much like the quick way to summarize this, because what needs to be said as well is that patients who are breathing by themselves or patients who are ventilated should be put into two very different categories, especially when it comes to tension pneumothorax. Because when we're breathing, we are not adding positive pressure, we are using negative pressure because that's how we breathe. When we inhale, our lungs expand, our diaphragm drops, and that causes a negative pressure in our lungs. That makes air rush into the lungs. That's Boyle's law. When pressure goes up, volume goes down, and vice versa. However, when you are on a ventilator or you're having BVM or positive pressure ventilation, however way you want to do that, what happens is that then air is pushed straight into the lung, and this then will obviously worsen your tension pneumo much quicker. We'll be discussing that a bit later on. So now that we've chatted about the why we are discussing this, let's chat about what. So what needs to really be said? What needs to be said is actually comes down to the diagnosis, because we all pretty much understand what a tension is, but not so much the diagnosis. So typically in school or in university or wherever you learned about this, we diagnose a tension pneumothorax on decreased lung sounds, hypotension, JVD, decreased lung sounds, hypotension, and shortness of breath. These are the ways that we've been told to diagnose. Oh, and there's the hyperresonance. If you read any evidence or if you look at any papers, you will see that the patient will become agitated and breathless. That's it. You won't see hypotension, you won't see hyperresonance, you won't see JVD, you won't see hypotension. These are not the signs that you're going to see. When I'm talking about these patients, I'm talking about the awake breathing patient, because it's different for a ventilated patient. So you need to also discuss maybe how the tension happened, because you get spontaneous tensions, you get medical caused tensions, you get trauma caused tensions. There's lots of reasons to have a tension pneumothorax. So the main things you're going to see is agitation and breathlessness. You're not going to see all of the cardiac related symptoms, all right? Because we're told, well, you are going to see hypotension, you're going to see JVD, you're going to see all these things, where actually there is more of a respiratory aspect to diagnosing these patients than there is a cardiac aspect. Because you were probably also told that there is a shifting of the mediastinum. In school, you were probably told that you're going to see a shifting of the mediastinum, which then bends all the major vessels, which then gives us bradycardia. That's what gives us JVD, because there's pressure on the superior and the inferior vena cava, and these are what cause the hypotension and the tachycardia, where actually they have proven this to be incorrect. The studies that assess the shifting of the mediastinum, which is just like the big thing that surrounds the heart and major vessels, is that it actually cannot shift. They looked at pigs, they gave pigs tension pneumothoraxes on one side, and they saw the shifting of the mediastinum, and so now they said, well, humans do the same thing. Where actually pigs have very soft, flexible mediastinum, where humans don't. So you're not going to see the typical cardiac signs, you're actually going to see the respiratory signs with a tension pneumothorax. It's also really important to note that a spontaneous breathing patient can have a tension pneumo develop over a long period of time. This could be a couple of minutes to a couple of hours. The later signs that you are going to see when the tension gets really bad is that you're going to see the patient's going to have a tachycardia, they're going to become bradycardic, they're going to have a drop in consciousness, and then they're going to die. But that's at the very end. So we can't be using hypotension and decreased level of consciousness or hyperresonance are just things that we're going to see in maybe like 10% of the cases. Even things as decreased air entry, venous distension, and those sort of things, you're only going to see them in like 30% of the cases, and you may only see them far, far late in the progression of the tension pneumo. When it comes to a ventilated patient, what you're going to see is that you're going to see an immediate change in their saturation. You're going to see a instant change in the pressures that you're trying to ventilate, and you're going to quickly have a patient deteriorate. So when you have a spontaneous breathing or a ventilated patient, they're actually very different, and you can't ask them, are you struggling to breathe if they're on a ventilator, because they're likely paralyzed and sedated. So when they are on a ventilator, it's actually just an index of suspicion, chest trauma, whatever the case is, and now they were fine, you intubate them and they suddenly become hypotensive, saturation drops, and you're going to see a very drastic change in these patients. Where you're spontaneous, you're not going to see that. When it comes to treatment, we typically, I'm not sure, depending on where you work, you're going to use a needle decompression or a finger tube decompression, which will happen on the lateral wall, or you're going to do a needle decompression in the second or third intercostal space. We're typically taught that when you do a needle decompression, that's going to fix the problem, and if you put it into the chest, well, that's that, you've done your job. The problem with needle chest decompression is that we often using needles that are too small. They don't reach the right pleural space. I'll drop a link for that. They get kinked, they get blocked, and then the patient needs to be re-decompressed, and so then we're putting more and more needles in, which puts more and more risk of us causing other problems. There are quite a few reasons for a needle decompression to actually have issues with the patient's mobility, because we can puncture other vessels, we can cause other damage, and sometimes we think it's worked where it hasn't, so that is quite dangerous. There's also research to say that it's better to do a needle decompression on the lateral wall in the fifth intercostal space, and that is because there's less tissue in between, and you're more likely to hit the pleural space with the needle you have. Or if you are doing simple or finger or tube thoracostomies, it's far better to just do it where you're supposed to be doing it, which is where we recommend you put the needle. And that this has other risks, but the benefits are is that you can quite easily re-decompress just with your finger, which makes things simple, as well as you are confirming that there's definitely no tension because you feel the lung wall with your finger. Where with a needle, you don't know whether it's worked or not, because air doesn't often rush out of the needle as we were told it does. In fact, in spontaneously breathing patients, it very seldomly rushes out because it's generally a smaller tension. Because if a patient is spontaneously breathing, they are able to compensate with breathing bigger breaths with increasing their tidal volume and their minute volume. However, when they're on a ventilator, they don't do that, and we're also positively pressure ventilating patients, which also causes other problems. So we've discussed the what is a tension pneumothorax, we've discussed how to diagnose, and now, as we're saying how to treat. So whether you can do your needle thoracentesis, or you can do a finger or tube, a chest drain, or whatever the case is, just be aware of the fact that how we diagnose these things isn't necessarily how we should be diagnosing. I'll drop a link to a very fascinating page or paper that I found. We should be aware of how we're treating it, because if we use a needle, it doesn't mean it's been fixed. We need to be aware of whether we've put a needle in or not. We need to actually check whether it worked. Do and check. We can't just do and assume it's happened, because there's this false assumption that once we put a needle in, it's 100% fixed. This is not true. And then, so that's what it is. That is, how do we diagnose and how do we treat? A quick story that I had was that I arrived on scene, and there was a paramedic on scene, and he was about to decompress, and I just stopped him and I said, hold on, why are you decompressing again? And he said, well, the patient's still short of breath. So I was like, okay, let's just assess more than that. And we found that he actually had an open chest wound. He had a sucking chest wound. So whenever the patient breathed out, air came out of the hole, and whenever he breathed in, air went into the hole. So obviously the patient is still short of breath. He never needed a chest decompression, because whenever he breathed in, air went in, but whenever he breathed out, air went out. So that isn't the definition of a tension pneumo. So we just put a 3-way dressing on there, and the patient went from the patient went from being short of breath to not short of breath. So that was a really interesting story. So guys, I hope you enjoyed this video. I know it was quite quick to the point, but would love to hear your thoughts on this and whether you've ever had an interesting case with a tension pneumo where maybe you missed it or you told someone else to get it. Guys, thanks for watching. Thanks for your time, and stay well. Bye for now.